What is the most exciting trial or some of the new therapies on the horizon that keep you glued to your computer screen?
So I think we've talked a lot about type 2 diabetes, and the focus here was on, that patient population affects almost 95% of the folks that, we're dealing with. But I think when we're talking about type 1, I think this class that we just talked about, these SGLT2 inhibitors, is showing actually quite a lot of promise in type 1 diabetes, and there's been a couple dedicated trials that have looked at that. One of the companies has submitted for a filing in Europe, and so we're looking to see a couple submissions this year, specifically for type 1 diabetes, and we don't have any oral medications for that community, and I think, I think that's going to be a big win to be able to kind of now have some other additional innovation and tools that the type 1 diabetes community can also benefit from.
I think, when it comes to the type 1 diabetic community, I think that the more recent publications did show significant benefit in patients with type 1s. One thing that we do need to consider, though, is the safety of the SGLT2 inhibitor class in patients that might be insulinopenic, because these are the patients that are going to be at greater risk of developing ketoacidosis. So when looking at using this class of drugs in patients with type 1 diabetes, it's important to recognize that these patients don't make any insulin. So the goal is actually to reduce the insulin needs, but not eliminate it, but also to take into consideration that patients with type 1 diabetics are also gaining weight. So it's also going to be beneficial in terms of containing some of that weight gain with intensification. Nonetheless, I mean, these recent publications certainly showed promise. And again, as adjunctive therapy to insulin.
Yeah, and I think that language will probably be very bold and centered when the FDA does approve these drugs. Again, to be clear, none of them have that indication right now, but I think regarding the ketoacidosis, I think it's something, it's something that we can counsel and prevent, but it just we need to be a little bit mindful, making sure, you're not putting that patient that you think is not going to be using their insulin or not going to be adherent, pump failures, alcohol, those are some high risk areas where we know we can counsel around to kind of prevent some of that. So I'm sure we'll see some language front and center when that indication comes.
So Tripp, I'm going to put you on the hot seat. I keep hearing about, when I think about exciting horizons and exciting developments, I keep hearing about 2,000 drugs in the pipeline, or 2,000 gene therapies in the pipeline. Any thoughts just generally about, we've got all these gene therapies in the pipelines, we've got exciting SGLT2 inhibitors and new therapies coming with diabetes. Even if we end up with the perfect gene therapy or the perfect drugs, are we going to still end up with problems?
So I'm going to spin that a little bit, because you're actually asking the question of what I wanted to say. What I'm really excited about, and we just circled the wagon, so to speak, with all our pharmacists and our students in the last month about our approach going forward. And a lot of it has to do with that very thing. The patients that we see, their therapies are often not maximized. Their regimens are not optimized. So we're actually going to, from a retail pharmacist standpoint, this sounds counterproductive, but our mission over the next year, 18 months, is to try to take some of these really, really complex patients and optimize their regimens and actually get them off some of these medications, because you see this carryover from year to year to year on a lot of them. Pharmacogenomics is one way that we can do that, and we're putting that in our program. Weight loss is something that we're going, diabetes prevention program will allow us to bill for some of that, which covers some of the costs. So we're putting our package together right now, but this is something that the pharmacists that are on staff at our organization, they really believe in, even to the point of functional medicine, making sure that there are nutrient components too that we don't always think about when we're taking care of these patients. And you look at access to high quality food. In a place like where I live, it's almost impossible to find affordable, high quality food. So just education on how you can do that and how that's not so scary. It's really, we've got some wonderful testimonials and case studies where this has been done in our practice by our pharmacists and just changed people's lives by just redirecting them on how they access food. So that's what I'm excited about. I'm excited that all these options are out there. if somebody's on 10 medications, do they really need to be on 10? Or do they really need to be on those 7 or 8 that are most important? And we can help with lifestyle modification on the other thing. And in the community, we've got enough touch points where we can keep reinforcing that over and over and over. Plus, there are more and more tools available for us to do this as well, whether it be apps or just picking up the phone or bringing people into the pharmacy for education opportunities and giveaways or whatever you do to get them in. There are just a lot of ways to touch these patients that we really are trying to impact.
Well, that's an excellent closing thought. Do you have any final thoughts, Dhiren, before we leave?
No, it's one that I say a lot, and it takes a village to take care of folks with diabetes, and so, just take advantage of all your resources and all the folks that can provide the touch points, because if we could have solved diabetes just with endocrinologists, we wouldn't be in this situation. If we could just do it with primary care doctors, and so it requires, all folks, all the way down from the community health worker, to that specialist, because there's just so many things that are involved with it.
So we have a newly minted resident, fresh out of residency. What would you, as a seasoned clinical practitioner, in closing, what nuggets would you provide to them with respect to diabetes, where we're going, what they need to be thinking about as they set out over the next 30 years?
I think that they need to be welcoming of change, paradigm shifts, avoiding inertia, because that's also another problem that we really didn't touch upon, is appropriate intensification. But it's also important to convey to this young resident, new clinician, that collaborative efforts, not just pharmacologically through the use of combination therapies and so forth, but also on a personal level with the use of multiple specialties, are really needed in order to get our patients to their ascribed targets and goals. And also keep reading. Learn about these new products that are out there that are going to be beneficial, that ultimately leads to a good outcome.
Well, that was a wonderful discussion. Thanks for your contribution. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. We'll see you next time.